Okay, good afternoon, everybody. My session today is on endocrinology, and I've got 90 minutes to cover as much as I can. So I've made it in a clinical cases format to make it interactive and cover many topics. These are the topics which I'll be covering. A few cases on thyroid dysfunction, hypogonadism, adrenal insufficiency, polycystic ovarian syndrome, diabetes and prediabetes, hyperparathyroidism and osteoporosis. So the first case is a 68-year-old lady with hypothyroidism who you see in clinic. She's on thyroxine 125 micrograms. Her weight is about 82 kilos. And you check her thyroid levels and you find the TSH is raised and the T4 is 14.6. The answer shouldn't have appeared, but I think there's a problem with the system. So I guess the first question is, what would you do when you see somebody with a raised TSH and a normal T4? And the first thing you should do really is check compliance, because quite often compliance is an issue with patients. And what I mean by compliance, it's not just whether they take the tablets or not, it's whether they take it at the right time. Because the best time to take thyroxine is first thing in the morning on an empty stomach. Because quite often food can interfere with the absorption of thyroxine. So the first thing is really, you advise the patient to take the thyroxine first thing in the morning, and they shouldn't eat anything at least for half an hour, ideally an hour. So if the patient is compliant, what you could do is increase the dose to 150, and then review the patient after 2 to 3 months to reassess. As a general guide, when you decide the dose of thyroxine, it tends to be 1.5 of the weight. So if a patient is 80 kilos, 125 should be the right dose. But of course, there's variability between patients. So the patient comes back after 2 months and the TSH is better. It's down from 13 to 9, but it's still elevated. And at this stage, you start thinking of other things. And one of the things you should think of is medications. What factors might be interfering with the thyroid levels? And this is the drug list of the patient. She's on simvastatin, ferrous sulfate, furosemide, and amlodipine. And the question to you is, which of these medications do you think might be impacting her thyroid levels? I think you've got some devices and you can choose your answer. So how do I know if the voting is done? Does it tell me, or? Next one. Okay, excellent. So the vast majority know that it's actually the iron tablets which interfere with the absorption of thyroxine. And quite often patients tend to be on both thyroxine and iron tablets. So what we advise patients that they should take their iron at least 2 hours after the thyroxine. Ideally 4, that might not be very practical, but at least 2 hours. And actually when she did that, after another 2 months, her TSH was 0.89. So always think about medications, make sure the patient is taking the medication at the right time of the day. This is a list of various medications which can interfere with the absorption of thyroxine. I've highlighted the common ones, things like bisphosphonates, proton pump inhibitors, iron tablets, calcium tablets, orlistat, things like ranitidine. So all these drugs can interfere with the absorption of thyroxine and cause problems with the levels. Other factors are gastrointestinal problems like celiac disease and certain types of food. Coffee can interfere with absorption of thyroxine, dairy products, and grapefruit juice. So it's worth checking these things with the patient. Other factors are GI problems. So H. pylori is quite common in the population, and people have H. pylori infection even if they don't have symptoms, and it can interfere with the absorption of thyroxine. So if we're really struggling, we can do a urea breath test, and if it's positive, the patient can have an OGD. In some patients, lactose intolerance, because lactose is one of the components of the thyroxine tablet. And if the patient has lactose intolerance, it can interfere with its absorption, so we can check for that. As mentioned earlier, you can do a check for celiac disease, and then do an OGD and make a diagnosis. And actually about 30% of people never achieve an ideal TSH because of various factors, whether it's GI problems or interfering tablets or lack of compliance. Okay, so a different case, a 26-year-old lady who you see in clinic who's got Graves' disease and is on carbimazole, which she's been taking for 2 months. And when you see her in clinic, she's complaining of a sore mouth, and you have a look and she's got some ulcers. But otherwise, she feels well. So I guess the question is, what blood tests would you order at this stage? Just give you a couple of seconds to think of that. And really what you need to do is a full blood count. So any patient who's commenced on carbimazole needs to be advised if they have a bad sore throat, if they have mouth ulcers or a rash or feel unwell, they need to have a full blood count because of the rare side effects of agranulocytosis. And this is actually a real case. When we checked her full blood count, her neutrophils were 0. So she had significant neutropenia. And the thyroid levels showed that she was slightly overtreated, that her T4 was low and her TSH was raised. So the carbimazole was stopped. She was actually admitted because of the neutropenia. She was started on granulocyte stimulating factor and broad-spectrum antibiotics to avoid neutropenic sepsis. And 6 days later, her white cell came up to 8.4. Agranulocytosis is quite rare. I mean, the incidence is 1 in 300. In the last 13 years in Barnsley, I've only seen 3 cases. But it can be dangerous. The mortality in some studies is up to 20%. It's an immune-mediated destruction of the neutrophils. So she was on carbimazole. We stopped the carbimazole because of the side effect, but she still has Graves' disease. She still needs treatment. And the question really, what is the next option now? Would you put her on propylthiouracil? Would you refer her for radioiodine? Or would you refer her for a thyroidectomy? And I'll give you the choice to choose the right answer. Okay, so a good proportion would go for propylthiouracil or for the radioiodine. The right answer actually is B. And the reason why it's B, because if somebody's had agranulocytosis on carbimazole, there is a very good chance that they would have the same side effects on propylthiouracil. So if they've had a problem with neutropenia, then we avoid PTU altogether. And we need to go for another option, which is either radioiodine or thyroidectomy. For most patients, we go for radioiodine. This lady is 26, so she's young. She might have young children. She might be planning for pregnancy, so we need to check about that, because there are contact precautions. If you can't stay away from her children for 2 to 3 weeks, if she's planning to get pregnant, then propylthiouracil is not the right answer. But in general, that would be the next step, unless there is a contraindication for propylthiouracil. Okay, another case. Again, this is a case which we've seen in the hospital. A 78-year-old man presents to you with palpitations. You find he's got atrial fibrillation. You check his thyroid levels, and he's hyperthyroid. T4 is 33.8, TSH is suppressed. So you commence him on carbimazole, and you refer him to the endocrine clinic. But in the meantime, after about a week, you check his full blood count, and his white cell count has dropped again. Neutrophils not as bad as the last patient, but it's 1.4, so it's below the reference range. So you stop carbimazole, and you refer for radioiodine. The difference compared to the other case is that this patient is still hyperthyroid. His T4 is 35. That lady, her T4 had dropped, so we had time really to plan further management. The problem here is that we can't really do radioiodine, because if somebody's got a T4 of 35 and you give them radioiodine, it might trigger a thyroid storm. So usually we tend to get the levels under control first, and then we do radioiodine or surgery. So it was a bit of a challenge. So what we did is, we did a thyroid uptake scan. I don't know if it shows very well, but That's basically the head. This is the neck. The plus sign is where the suprasternal notch is. And that horseshoe shape is the thyroid. These are the salivary glands. And if you look at the thyroid and compare it to the salivary glands, it's quite faint. So it's a very low uptake. And if you look at the uptake, it's only 0.2%. So really, this wasn't Graves' disease. Any idea what it might be? This was actually thyroiditis. So in thyroiditis, you can get raised thyroid levels. You can get the same kind of symptoms of Graves' disease, but it's basically inflammation of the glands, release of large amount of hormone to the circulation, which with time will settle. So you have a hyperthyroid phase, followed by a hypothyroid phase, then it goes back to normal in most patients. And the advantage in this case is that this patient doesn't need treatment, just monitoring, and with time it would settle. So he was having weekly bloods. After 3 weeks, his T4 dropped from 35 to 24, then to 19, and after 2 months from presentation, he started going through the hypothyroid phase, and that his TSH started going up. And most patients then recover after that, but in some patients they remain permanently hypothyroid. This is just to show you the causes of thyroiditis. The most common tends to be what we call subacute or viral. It can be bacterial, which is acute, chronic autoimmune, or postpartum. This is something we see quite often after pregnancy. It tends to happen mainly about 6 months after pregnancy, especially in ladies who have positive thyroid antibodies. This is just to show you a different scan of a different patient. This is a patient with Graves' disease, just to look at the difference. So you can see how bright the thyroid gland here, and the uptake was 5.4%. So this is a classical Graves' disease picture. Okay, so a different case. A 62-year-old lady is reviewed in your clinic, and you order some tests. HbA1c is 7.2%, 55, which is reasonable. Cholesterol slightly higher than target. But again, looking at the thyroid levels, TSH is raised at 7.3, upper limit of normal is 5.5, and the T4 is in the normal range. So what is the diagnosis here? So subclinical hypothyroidism, which again is relatively common, and the question is really when to treat. Before you decide about treatment, you need to ask some questions. If the patient has got any signs or symptoms of hypothyroidism, tiredness, problems with weight, constipation, low mood, if there's any past history of thyroid problems, if there's any family history of thyroid problems, or if she's on any medication which might cause abnormal thyroid levels like amiodarone or lithium. Then another test which is worth doing is checking the thyroid antibodies, the thyroid peroxidase antibodies. Because if they're negative, then you're less inclined to start treatment. But if they're positive and the patient is symptomatic, then you would start some treatment. So if they're negative, patient asymptomatic, you can simply just repeat the test in 3 months' time and reassess. In general, if somebody's got subclinical hypothyroidism, meaning the TSH is raised and the T4 is normal, if the TSH is above 10, on more than one occasion, that you would start treatment. But if it's below 10, then you're guided by the symptoms and the antibodies. Let's say the TSH was 7, she's feeling tired, struggling with her weight, and she's got positive antibodies, then there is a case for starting thyroxine, because she's more likely to progress to overt hypothyroidism sooner or later. Okay, another case, 35-year-old lady. You see, she has areas of skin depigmentation. You make a diagnosis of vitiligo, and you check her thyroid levels. She's got a low TSH of 0.1, T4 normal 17.1, and a T3 normal of 4.2. So again, the question here, when you're faced with these results, especially if you repeat them and they're consistent, what is the possible etiology? So one possibility is subclinical hyperthyroidism. So the opposite of subclinical hypothyroidism, where you have a low TSH or suppressed TSH with normal T3 and T4. It could be simply resolving thyroiditis, that the T3 and T4 have settled and the TSH is taking its time. Or what we call CQ thyroid syndrome, or non-thyroidal illness. So if somebody's had a flu or has been in hospital unwell, sometimes the TSH can slightly go out of range and within a few weeks' time settle down. Subclinical hypothyroidism, in a way, is a mild form or early form of hypothyroidism. So these patients may well progress into Graves' disease or hypothyroidism related to a toxic multinodular goiter. So how would you manage this patient? It's worth looking for signs of thyroid disease, checking for a goiter, any evidence of thyroid eye disease, because that would go with Graves' disease. Again, checking the antibodies. The more relevant antibody here is the TSH receptor antibody, because that's specific for Graves' disease. If you're suspecting thyroiditis, you could do an ESR. But if all that is negative and the patient's feeling well, you can simply repeat the test in 3 months' time. When to treat subclinical hypothyroidism? There are various guidelines. There's the American guidelines, European guidelines, but in general, if the patient is more than 65 years old and the TSH is fully suppressed, i.e. less than 0.01, then the general guidance is to start treatment. However, if the TSH is low but not suppressed, then you could simply just monitor. If the patient is less than 65, then you look at the comorbidities. If they've got heart disease, for example, atrial fibrillation, heart failure, ischemic heart disease, you would treat. If they've got osteoporosis, if the lady is postmenopausal, or if they've got symptoms and the TSH is suppressed and they're less than 65, then the advice is to treat. But otherwise, you can just monitor the patient every 3 to 6 months.
Excuse me.
Yeah.
You see a lot of these men postmenopausal, borderline hypothyroid,
Yes.
no symptoms.
Yeah.
You suggesting that we should treat.
Well, yes, the general guidelines is suggest treating. However, there isn't really any strong data to support that. I just put that up just for guidance, but I think one of the slides which is coming up does say that there isn't really strong evidence to say if you treat this patient, you're necessarily going to change the outcome. If you treat it. However, if the patient's got osteoporosis and she's got atrial fibrillation, then that is a case for treating. Yeah. Yes.
Because I've heard people to endocrinology with AF who can't have their subclinical hypothyroidism treated.
Okay. Well, if they have atrial fibrillation and they... Sure. Yes. Indeed. In general, the advice is to start treatment, especially if it's suppressed, the TSH. Yeah. I must say the guidelines are not clear-cut, but if the patient has AF, I would start treatment. Yeah. So the overall, there's about 5% risk of progressing to overt thyrotoxicosis per year in somebody with subclinical hypothyroidism. In a meta-analysis involving 5 studies, there was increased risk of AF, a 68% increased risk above the normal population. Other comorbidities, they can develop heart failure if it's for many years and untreated, osteopenia and osteoporosis. And in another meta-analysis which involved almost 50,000 patients, there was an increase in all-cause mortality by 24%. So it is associated with comorbidities and mortality. However, there isn't really strong evidence that necessarily treatment is going to make a difference. But I think if they have AF, then I would treat. And actually, there's some evidence if somebody has a TSH which is not suppressed, just slow, and you treat them, you might end up pushing them the other way and they become hypothyroid. So it really depends on the patient, their age, and the presence of comorbidities like heart problems and osteoporosis. So the next case is a 39-year-old lady with hypothyroidism for about 6 years and hypertension. She's on thyroxine 75 micrograms and ramipril 5 milligrams. And she's planning to get pregnant. And she asks you about her medication. So you do some tests, you check her thyroid levels, her TSH is normal at 3.2, and her blood pressure is 130/75. So the question, what would you do at this stage? Would you stop the ramipril and continue thyroxine as it is? Would you stop the ramipril and adjust the thyroxine? Or would you just simply continue both as they are? Okay, so yeah, so obviously most people went for the Right answer, you would stop Ramapil because Ramapil is contraindicated in pregnancy. Other options, you could use methyl dopa, labetalol, nifedipine slow release. But for the thyroid, although the TSH is normal, it's not optimal. So usually in the first trimester of pregnancy and preconception, we try to optimize the levels, aiming for a TSH of less than 2.5. Within the reference range, but less than 2.5. And in the second and third trimester, you aim for a level of less than 3. So B is the right answer here. So you'd go up to maybe 100 micrograms and recheck after. We would recheck here about 2 to 4 weeks later. I mean, normally you check after 2 to 3 months, but if somebody's trying to get pregnant or if they're pregnant, we tend to monitor quite closely to ensure the levels are improving. Yeah.
Would you monitor a pregnancy based on TSH or treatment?
During pregnancy, we look at both, but we look at TSH. When it's hypothyroidism, it's mainly we're looking at the TSH. When it's hyper,
Electricity, someone who's already on thyroid.
yes, it's the TSH. It's the TSH.
And we aim to keep it
Below
below 2.
2.5 in the first trimester, obviously above 0.38, but below 2.5. And in the second trimester, below 3. Yeah?
Again, TSH, somebody's undergoing fertility treatment.
Yes.
Should we be a bit more close control with the TSH as well?
Yes, of course. I mean, obviously, if somebody's not on treatment, you wouldn't start treatment if the TSH is 3.5. But if they are on treatment, you would want to optimize the levels. Yeah? Yeah.
Just that I think given a narrow range for the TSH.
What range have you been given?
I can't remember, I think it was 2.5 to 3.5 TSH or
Between those two figures?
yeah.
It's a very narrow kind of range. Yeah.
It was from Jessup.
Okay.
I can't remember if that was the range, I'm pretty sure the top was 3.5.
When we have a similar operation in TSH, the main thing below 3.
There goes.
Yeah? Yeah. So I'll show you the next slide, and just to show where these figures come from. So this is basically a study in normal, healthy pregnant ladies, not ladies with thyroid problems, and we can see that most pregnant ladies have a TSH of less than 2.5 in the first trimester, and that's why we use that cutoff. And in the second and third trimester, most ladies have a TSH of less than 3, and that's why we use that cutoff. So it's really based on the healthy population. Okay, so this is another graph in about 13,000 healthy population looking at the TSH, just to see what the TSH is in the normal population. And although the reference range of the lab goes up to 5.5, you can see that the vast majority of people have a TSH of less than 2. And that's why if you're treating somebody with hypothyroidism and they're still symptomatic, and the TSH says 3 or 4, although it's normal, you can say it's not optimal, so that you have room for pushing up the dose to try and optimize their TSH levels. You don't want to suppress it, but try and get it below 2. Okay, so that was a few thyroid cases. Changing topic now. So a 39-year-old man presents with erectile dysfunction for over a year. His examination is unremarkable. And I guess the question, what tests would you do? So obviously this is a common thing we see in Barnsley. And one of the main tests you would want to do is testosterone. And usually we tend to do fasting testosterone because naturally the testosterone levels do drop as the day goes by, and food can have an impact on the levels of testosterone. So this patient had a fasting testosterone of 3.1, which is quite low. And usually when you check the testosterone, it's important to check the LH and the FSH with it, because that will tell us whether it's primary, related to the testicles, or is it secondary, related to the pituitary. And this patient has a low LH and low FSH, so it's hypergonadotrophic hypogonadism. Another important test to do is the prolactin. And this patient had a significantly high prolactin of 6,580, upper limit of normal 370. We also check the thyroid levels as a routine in somebody with erectile dysfunction and exclude diabetes. Up to 50% of people with diabetes have erectile dysfunction. So it's always important to check for diabetes and ask diabetic patients if they have this problem. So prolactin was significantly high, secondary hypergonadism, so we arranged an MRI, and that showed the patient had a pituitary macroadenoma, so a large pituitary tumor. So high prolactin with an adenoma, basically this patient had a prolactinoma. So if you simply just check the testosterone, not check the prolactin, you would miss that. So it's important to check the prolactin. Any patient with a lump in the head, you should ask about symptoms of headaches or visual field defects, especially in pituitary problems. And they should have a proper visual field assessment. So treatment, how would we treat this patient? So although they have got low testosterone, but they have another problem, which is the high prolactin. So first thing you would treat is the prolactin. And the medication we use is cabergoline, which is a dopamine agonist. It's used twice a week, and the dose can be titrated as needed. And in this patient, within 4 weeks, the prolactin dropped from 6,500 to 400. And after about 6 weeks, the testosterone came on by itself from 3.1 to 8.9 without the need for testosterone replacement. 2 years later, the patient had a repeat MRI, and the tumor shrunk from 1.9 centimeters to 1 centimeter, and the testosterone was 18. So it's just to show that by treating the hyperprolactinemia, the testosterone rectified itself from 3 to 18.
Sorry.
Yeah.
See hyperactive drugs, psychoactive drugs.
Yes. Yes.
That cannot be disordered.
It can. I mean, very high prolactin can affect your testosterone. Therefore, in general, I wouldn't check the prolactin if the patient has got any symptoms, if they're on antipsychotic medication, because you'd expect the prolactin to be high. Yeah, and I'm not sure why they do ask for it, because if the patient is asymptomatic, the prolactin is going to be high. Yeah? So, and we get referrals from psychiatrists also. They check the prolactin and it's high, they send the patient to us. But if the patient has got any symptoms, you end up doing an MRI scan, just to exclude there's no pituitary lesion. But the problem with that is sometimes, 10% of people have an incidental microadenoma. So if you find an adenoma in the pituitary, that doesn't necessarily mean it's the source of the high prolactin.
But that's a conundrum. I mean, we can't leave it upon what is prolactin is 3,000 millimeters.
Well,
Still have to do an MRI.
yes, if the patient is referred to, you're going to...
Find something is not necessarily causing problems.
Yes, so then the only thing you can do is to stop the tablet and see if the prolactin settles. But it might be difficult to stop the tablet. So it's a difficult situation. That's why if they haven't got the symptoms to start with, it's really questionable why you're doing the test. Because it's going to be high. Yeah. So if it's a lady and she's got menstrual problems, yes, you can check the prolactin. If it's a man with erectile dysfunction, yes, you can check the prolactin. But if the patient's completely asymptomatic, the prolactin is going to be raised. This is just to show the scans of this patient. I don't know if they show very well, but that's the pituitary. This is the cella-thoracic, and the pituitary is sitting in the cella-thoracic. You can see it's quite rounded and globular, so it's enlarged. That fine line there is the optic chiasm. So it wasn't quite pressing on the optic chiasm. And this is 2 years later. You can see how it's flattened, so it's shrunk with the treatment, with the cabergoline. This is just simply a different patient, just to show you how large tumors can be. This is a very large pituitary tumor, and it's actually stretching the optic chiasm. And that's when they can get the visual field problems. Okay, so prolactinomas are actually the commonest pituitary tumors. About 40% of all pituitary adenomas are prolactinomas. They tend to be divided depending on the size, if they're less than 1 centimeter or more than 1 centimeter, to micro and macro adenomas. Obviously, when they're macro, they can press on the surrounding structures. They're more common in females. But as mentioned earlier, 10% of the normal population have incidental microadenomas. They're just non-functioning, sitting there doing nothing. So that sometimes can blur the picture. This is just to show you in a coronal section. That's the sphenoidal sinus, the cella-thoracic. This is the pituitary, and this is a microadenoma sitting in the pituitary. That's the pituitary stalk, and that's the optic chiasm. So if it's a large tumor and goes up, suprasellar extension, it will press on the optic chiasm. If it's an aggressive tumor and breaks through this thin bone, it can extend it to the cavernous sinuses. These are all cranial nerves, so it can damage the cranial nerves. So in aggressive tumors, it can cause a lot of problems. There are various causes for hyperprolactin. There's physiological causes, sexual activity, exercise, obviously lactation and pregnancy, stress. Even the pain of the venous puncture can cause raise in prolactin. That's why sometimes we do cannulated prolactin. So the patient comes, we put a cannula in, and the prolactin is checked after 30 minutes, 60 minutes, and 90 minutes, and we see the prolactin levels drop back to normal if it's simply related to the stress of the venipuncture. Obviously, there's various pathological causes, whether it's hypothalamic or pituitary, prolactinomas being the common one. Systemic causes like renal failure, seizures. If somebody has their prolactin checked after a seizure, can be raised. And then polycystic ovaries is another cause of raised prolactin. Even sometimes stimulation to the chest and the nipples can push the prolactin up. So if somebody's got shiggles around the chest, the prolactin can go up. And then there's various drugs, as you mentioned earlier, the antipsychotic medications, anticonvulsants, and antidepressants. Okay, so a different case, a 25-year-old man, again presents with lack of energy, reduced libido, and erectile dysfunction. So you do your blood tests, and again, testosterone is low at 7.8. LH and FSH are normal. If it's normal, that goes with secondary hypogonadism, because if it's primary, the levels should be elevated. In this case, this patient's prolactin is actually normal, so it's not related to prolactin. So what questions would you ask in the history, trying to look for the cause of this low testosterone? You know, patient's relatively young. Well, he's young, he's 28. And these are the things which you want to find out if they've had head injury, because there is evidence if somebody's had a bad head injury, they may develop hypopituitarism after many years. You ask about orchitis, testicular injury, which is more relevant to primary hypogonadism, it's the problems in the testicles. But in a young man, especially if he's looking quite fit and muscular, you need to ask about the use of anabolic steroids, which is something which we quite often see in the clinic, and quite often the patient denies it, and after 3 to 4 visits they admit that they've been using anabolic steroids. So it's worth checking that. Obviously it's a secondary hypogonadism, so you need to check the rest of the pituitary hormones and do an MRI of the pituitary. Even if it's related to anabolic steroids, you still need to be on the safe side and do the scan. Okay, so this patient is young, he's 28, and he's got hypogonadism and needs treatment. So what are the options? When it comes to treatment of hypogonadism, most patients we treat them with testosterone. So the body is lacking testosterone, it's testosterone replacement. However, if you've got somebody young, you need to think about fertility issues. If they're planning to have children, you know, if they've finished their family, if they've had a vasectomy, and if the patient is keen to have more children and you put them on testosterone, that is going to suppress the gonadotrophins further, and by suppressing the FSH, there's no stimulation to the testicles to produce sperm. So if somebody is young and keen to have children, we tend to avoid testosterone and we put them on gonadotrophins. You need to have a baseline sperm count to see where things stand, and then we tend to repeat it 3 months after commencing treatment. And the drugs we tend to use, is HCG, which is similar to LH, so that mainly stimulates the testicles to produce testosterone, and maybe sperm also. But if that doesn't work, we add in FSH. The main drawback is that these are given as injections subcutaneously 2 to 3 times a week. So if the patient's on both of them, that's 6 injections a week, which they administer themselves. But it's important, especially if the patient is keen on fertility, to maintain the sperm count. This is just a flow chart about how to investigate patients with erectile dysfunction and symptoms of low testosterone. So obviously you start with history and physical examination. You check their morning testosterone, ideally fasting. If it's normal on more than one occasion, then obviously it's not hypogonadism related. If testosterone is low, you want to know if it's secondary or primary. And the main thing to check is the LH and the FSH, and also prolactin. If it's secondary, then you do an MRI. If it's primary, then obviously you examine the testicles. The patient might need an ultrasound of the testicles, and you can check for Klinefelter syndrome. So Klinefelter syndrome is XXY, and it's actually quite common. 1 in 500 people have Klinefelter syndrome, so much more than you might think. But the way people present varies. So some people live their whole life without knowing they've got it, And some people might present quite early in life with features of hypergonadism. This is just a table of the various causes of hypergonadism. So if you're looking at primary hypergonadism, Klinefelters, undescended testicles, trauma to the testicles, orchitis. If somebody's had radiotherapy in the area, that can damage the testicles, like prostate cancer, for example, testicular torsion. And then there are the secondary causes, which relate to the pituitary and the hypothalamus. Medications, opiates. Opiates are an important cause of hypopituitism. Quite often we see patients on high doses of morphine with hypergonadism. Even low cortisol can be related to high doses of morphine. So it's worth looking at medication. Okay, so moving on to a different topic. 63-year-old man who you see in clinic who presents with episodes of recurrent hypoglycemia. Quite often, 3 to 4 times a week. And the past history includes diabetes, hypertension, and he's had a gastric bypass surgery a couple of years ago and lost an impressive 60 kilos after surgery. And the question is, what's the likely diagnosis? Why do you think this patient is having hypoglycemia? Say that again? Indeed. So first thing to think of, this patient's got a history of diabetes, and is he still taking his medication, which might be a cause? Some studies have shown that 80% of patients are cured of their diabetes after having gastric bypass surgery. So it's a very effective way of treating diabetes. And if the patient is still taking their medication, then they might end up with hypoglycemia. However, in this case, it was something else. Any ideas? So it was what we call late dumping syndrome. So that's one of the complications of gastric bypass surgery. And quite often it presents with hypoglycemia occurring 1 to 3 hours after having the meal. And really it's related to change of anatomy. So simply it's by the food dumping through the intestine. Body reacts by releasing large amounts of insulin. And because of the change of anatomy, there's a mismatch and patient ends up with hypoglycemia. And they end up with having hypoglycemia almost on a daily basis after their meals. Present with classical symptoms of, feeling sweaty, lightheaded, confused, an hour or two after having a meal. So usually management is by dietary adjustments. We advise the patients to have smaller meals, maybe 6 small meals rather than the 3 standard meals a day. Avoid fluid with their meals. Avoid what we call high glycemic index food, which is rich in sugar. And increase protein and fiber. That tends to work in most patients, but if it doesn't work, we can use acarbose, which delays the digestion of carbohydrates. And in really severe and resistant cases, sometimes we use what we call a somatostatin analog, octreotide, which slows down the emptying of food in the intestine. This is just to show the various causes of hypoglycemia, things to think of. Drugs like, obviously, insulin, the most common one, gliclazide. If somebody's septic, they can have hypoglycemia. If they've got hepatic, renal, cardiac failure, adrenal insufficiency. So especially patients type 1 diabetes, been stable for a while and suddenly developing hypoglycemia with no clear reason. We check for Addison's because, both autoimmune conditions. Then there are less common things like insulinomas and various pancreatic pathologies. Another thing to think of, this is actually a case we saw a few months ago, is accidental. We had an elderly demented lady who was taking her husband's gliclazide and presented with hypoglycemia. So these are things worth thinking of. Okay, so next case is a 57-year-old lady who you see in the diabetes clinic. She's had diabetes for about 4 years. She's got BMI of 34, so obese. And she's on a full dose of metformin, full dose of sitagliptin, and her HbA1c is 67, 8.3%. So not really ideal control. So I guess the question is, what would you do here to improve her control? I'll give you a couple of seconds to think. So any patient you see with poor control diabetes, it's worth first going through lifestyle adjustments, just to make sure that they're still following a good diet, because really most patients don't follow a good diet. It's always worth reiterating the importance of improving their diet, see if they're exercising, She's already on full dose of 2 agents. Her HbA1c is above 58, so at this stage you would add a third agent. If you add the glycoside, then it's not going to help her weight. So really an SGL2 inhibitor would be an option here. SGL2 inhibitors work by inhibiting the reabsorption of sugar in the kidneys, so simply patients are weaning out the sugar, and that helps their diabetes. An important thing about SGL2 inhibitors, which we are seeing more often in the hospital, is the risk of diabetic ketoacidosis. And one of the problems is that because the patient is weaning out the sugar, they can develop ketoacidosis without a high blood sugar. So you check the blood sugar, it might be 10, so you wouldn't think of ketoacidosis. And recently we had a patient on the medical admission unit who had a sugar of 11, who was really unwell with a pneumonia. And when we checked the ketones, they were 5, and the pH was 7.29. So it's always worth thinking of that in a patient on an SGL2 inhibitor. And all patients should be provided with a ketone meter to check for ketones if they're clinically unwell. If for any reason the patient can't take the SGL2 inhibitor, then another option here is a GLP-1 analog, like Byetta, Victoza, or Trulicity, which is the once-a-week one. And then you review the patient after 3 months to reassess. This is just to remind you of the NICE guidelines. So any patient newly diagnosed with diabetes, you'd start with diet and lifestyle adjustments. You give them 3 to 6 months of that. Obviously aiming for an optimal level of an HbA1c of 48, which is 6.5%. If that's not achieved, then you introduce metformin as the first line. Always remember, if the patient can't tolerate metformin, it's worth trying metformin MR. And patient tolerates it very much better. You give them another 3 to 6 months. Still HbA1c above 58, then you add a second agent. And really the choice of the second agent depends on the patient, their age, the risk of hypoglycemia, other comorbidities, their weight. So you can choose any of these 4 depending on those factors. And then another 3 to 6 months, still no improvement, then you add a third agent. And towards the latter stages, it's either GLP-1 analog or insulin. How strict you are with the management of diabetes depends on the patient. So you tend to be more strict if the patient's really motivated and engaging, because if the patient is not motivated, not bothered, you're going to struggle whatever you try to do. The risk of hypoglycemia, if somebody's a driver, if somebody's elderly living alone, then you want to avoid strict control to avoid hypoglycemia. Duration of diabetes, if it's newly diagnosed, you tend to be more strict. If the patient's already developed the complications, then you tend to be less strict. And obviously the availability of resources plays a factor. And these are actually international guidelines, the European and American guidelines. Okay, so another case, a 37-year-old lady who's had diabetes for 5 years, got hypertension and renal impairment. You check her EGFR is 49, HbA1c is 63. She's already gone through lifestyle adjustments and control hasn't improved. And she's just moved to a surgery and you want to start some treatment. So which of these 4 options would you go for in this patient? Yes, good. So that's what I would do. So I'd go for metformin. Tremains is the first line. One of the most tablets we have. And although the EGFR is 49, that's not a contraindication to using metformin. If metformin is less than 45, then you tend to avoid it. But if it's more than 45, you can still start it, but you start with a smaller dose, and you would monitor the EGFR more frequently, every 3 months rather than every 6 to 12 months. But it can still be used. Gliptin is still a viable option here. With linagliptin, it's a standard dose of 5 milligrams. If you go for sitagliptin, as the EGFR is less than 50, you wouldn't give the standard 100, you would start with 50 milligrams. Gliclazide still can be used, but in people with renal impairment, there's a higher risk of hypoglycemia. So really, A, B, and D are all possible answers, but I would start with metformin here. The only one which you can't use is the SGL2 inhibitors. And the reason being is that the EGFR is less than 60. So if the EGFR is less than 60, they're contraindicated. If somebody is already on an SGL2 inhibitor, and it drops below 60, and it's between 45 and 60, you can continue, but you need to lower the dose. But if they're not on it already, then you shouldn't start it if the eGFR is less than 60. Okay, so another case is a 64-year-old lady who's known to have diabetes, COPD, and adrenal insufficiency. She presents to you with a 3-day history of diarrhea and vomiting, feeling quite tired, blood pressure is a bit on the low side, and the question here, what would you do? Would you encourage her to increase her oral intake and give her some loperamide for the diarrhea? Would you give her IV or IM hydrocortisone and send her to hospital? Or would you double the oral dose of steroids and ask her to continue on the double dose until she's better? So which answer would you go for? Okay, so it's almost half-half. Half of you would give her parenteral hydrocortisone and send her to the hospital, and half of you would ask her to double the dose. The right answer really is B. And the reason why it's B here is that this lady is vomiting, her blood pressure is on the low side, she's feeling tired. If you double the oral dose and she's vomiting, then really she's not going to keep it down, so that is not necessarily going to help. And the fact that she's tired and her blood pressure is low does indicate she might be heading towards an adrenal crisis. So really in general, if somebody's got diarrhea and vomiting and feeling unwell, they need to have parenteral hydrocortisone and sent to the hospital. All patients are provided with an emergency kit of hydrocortisone 100 milligrams to take intramuscular. Some patients are happy to do it themselves and some might need help. But to avoid the risk of adrenal crisis, these patients need to have parenteral hydrocortisone and sent to hospital. All our patients are advised about sick day rules. So if they're unwell with, for example, a flu, fever, or any illness which requires bed rest, or antibiotics, they're advised to double their steroids and continue with a double dose for 2 days after they're back to normal. However, if they have diarrhea and vomiting, if they're feeling really unwell, then they need to have the IM hydrocortisone and seek medical advice. And another thing we provide our patients with is this kind of guidance, which is really for the health professional, but so the patient can hand it to the health professional. It's available on this website, and it's quite useful. It gives the various kinds of procedures and what needs to be done about the steroids. So if the patient's got major surgery, going through labor, having a tooth extraction, having a colonoscopy, it just advises the health professional what they need to do, like giving them hydrocortisone before the procedure, and what they need to do after the procedure. And it's quite important to avoid the risk of adrenal crisis. Okay, so moving on to a different case. 56-year-old man who's had a previous transsphenoidal surgery for pituitary non-functioning macroadenoma. The patient's developed hypopituitarism from their surgery. He's on hydrocortisone, he's on thyroxine, and on testosterone. You do some blood tests and you check the thyroid levels. You've got a T4 of 17.8, which is upper end of the normal range, T3 4.8, and a suppressed TSH. And the question here, what would you do? Would you continue the same dose of thyroxine, 100? Would you reduce it to 75? Or would you reduce it to 50? So please choose your answers. Okay, so most of you would reduce the dose to 75 micrograms, but 28% went for the right answer, which is you continue on the same dose. And the reason I put this case, because this is something which we tend to see. This patient has had pituitary surgery, so really she or he has secondary hypothyroidism. So in primary hypothyroidism, when the thyroid levels go up, the TSH goes down, thyroid levels go down, TSH goes up. But when it's secondary hypothyroidism due to a pituitary problem, the TSH is always going to be low. So really you ignore the TSH and you just look at the T3 and T4. So if somebody's had a pituitary problem and they're hypothyroidism is related to the pituitary, you're guided by the T3 and the T4, and the TSH is always going to be low. So in this case, as the T3 and T4 are normal, patient's feeling well, you just continue with the same dose and do not reduce the dose. Okay, so next case is a 26-year-old lady who presents with hirsutism, oligomenorrhea, and difficulty losing weight, no other past history, so really a kind of classical picture of polycystic ovarian syndrome. So you suspect that, but it's important to consider other possibilities as a differential diagnosis. So these are the other things which we tend to think of when we see these patients in clinic. Non-classical CH, it's relatively rare, but it's not as severe as classical congenital adrenal hyperplasia. Patients present later in life and usually present with things like hirsutism or menstrual disturbance. You know, any patient with Cushing's, with hirsutism, we consider Cushing's as a possibility, hypothyroidism, and less common is an androgen-producing tumor, whether it's an adrenal tumor or an ovarian tumor. So you do some investigations, you check the testosterone, and the testosterone is slightly elevated. The upper limit of normal for female is 2.1. And usually in polycystic ovaries, it's either slightly up or just high normal, but usually the free androgen index tends to be elevated. In case of tumors, you expect a testosterone above 5. So with this kind of level, you're not worried about the tumor. We tend to check the gonadotrophins, and usually the LH tends to be raised compared to the FSH. Prolactin sometimes is elevated in polycystic ovaries. It's always important to check the HbA1c in somebody with polycystic ovaries because there's an increased prevalence of impaired glucose tolerance and diabetes. And for completion, we would do an ultrasound of the ovaries. So polycystic ovarian syndrome it's quite common, affects 10% of women. The diagnostic criteria, you need 2 out of 3. So you don't have to have all these 3 features, but 2 out of 3 menstrual disturbances, oligomenorrhea, amenorrhea, features of hyperandrogenism, whether it's clinical or biochemical, and then you do an ultrasound which shows polycystic ovaries. The ultrasound is sensitive in about 90% of cases. So you have a normal ultrasound, it doesn't exclude the diagnosis. And it's not really necessary because if you have 2 out of 3, that's enough for the diagnosis. Classical findings is more than 20 follicles per ovary and then ovarian volume of more than 10 mils. Insulin resistance is one of the major components of polycystic ovaries. Therefore, we always check for diabetes. So other comorbidities with polycystic ovaries, things like acne, alopecia, acanthosis nigricans, which is the kind of dark brown discoloration on the armpits, skin tags. Quite often patients present with infertility, difficulty conceiving. If they do get pregnant, there's higher incidence of gestational diabetes, preterm labor, and preeclampsia. There's some evidence that there's some increased risk of endometrial cancer. Not high enough to warrant any regular screening, but there's some evidence there's a slight increase. Quite often patients are obese, but you can have slim patients with polycystic ovaries. Some patients are depressed, increased incidence of obstructive sleep apnea, and diabetes. Okay, management of polycystic ovaries. I mean, quite often management is not always satisfactory to the patient. Not all patients are really satisfied, and it is a difficult condition to treat. So lifestyle changes, trying to lose weight by diet and exercise. The main treatment is really the combined oral contraceptive pill. And the one we tend to use in clinic is the Dinet. Dinet contains cyproterone acetate, which is an anti-androgen. The drawback of that, it has a higher risk of DVTs. So obviously you need to check the patient hasn't got a strong family history or previous history of thromboembolic events. You have to not be smoking. Metformin is sometimes used. Metformin is mainly used to try and regulate the periods. It does have a role in stimulating ovulation. Sometimes we use Venica cream, which is it's not a hair removal cream, it's a cream which stops new hair from growing. Works in some patients find it useless. Then there's inofolic or inositol, which is considered an experimental therapy. Patients can buy it over the counter. It's not available for prescription. And it really works by reducing insulin resistance. And then there are obviously options for fertility, which are mainly done by the gynecologist. Clomiphene citrate, exogenous gonadotrophins, and sometimes laparoscopic ovarian surgery or drilling to induce ovulation. So just a few words on inositol. As I said, I mean, it's not something I've actually tried because it's not something to prescribe. Patients can buy it over the counter. It's an intracellular second messenger, and it regulates a number of hormones, including insulin. And it has a role in reducing insulin resistance because the high levels of insulin are the drive behind stimulating the androgen production by the ovary. So by reducing insulin resistance, that's how the inositol works. Okay, so moving on to a different topic. A 62-year-old lady presents with lethargy and mild confusion. You do a confusion screen and a calcium is 2.8. So obviously hypercalcemia. And I guess the question, what is the one test you want to do to try and clarify the cause of hypercalcemia? So the two commonest causes of hypercalcium are hyperparathyroidism and malignancy related, whether it's bone metastasis or a rise in the level of the parathyroid, the parathyroid hormone related peptide. This lady has a normal parathyroid hormone, and usually if the parathyroid hormone is normal or elevated, that goes with hyperparathyroidism. If the parathyroid hormone is suppressed, that goes with malignancy. Of course, there's other causes for high calcium. Sometimes it can be iatrogenic. If somebody's taking high doses of calcium, sometimes certain types of antacids contain high quantity of calcium. And once we had a patient who presented with a calcium of 3.8, very, very high. And it turned out she was taking huge doses of antacid over the preceding 6 weeks. So these are things to think of when you see somebody with high calcium. But this lady basically had hyperparathyroidism. Her PTH was high normal. And one other condition which we tend to exclude in clinic is something called familial hypocalciuric hypercalcemia. It's a benign condition. It's related to a defect in the calcium sensing receptors. So although the calcium is elevated, the body doesn't sense it and keeps stimulating by releasing PTH. The main difference is the calcium in the urine tends to be low in this condition, while calcium in the urine tends to be high in primary hyperparathyroidism. So what further tests would you do in somebody with hyperparathyroidism? You would check the 24-hour urine calcium and calcium excretion. We tend to do an ultrasound of the kidneys to see if they've got any kidney stones or nephrocalcinosis. We do a bone density scan because one of the complications of hyperparathyroidism is osteoporosis. And if we decide to send the patient for surgery, we do a MIBI scan, which is an isotope scan, an ultrasound of the neck to identify which of the 4 parathyroid glands is the one which needs taken out. This lady's calcium was 2.8, which is not very high. And usually if the level was less than 2.85, we just monitor. However, if the levels are significantly elevated above 2.85, then they need IV fluids, IV bisphosphonates to bring the levels down. Not everybody with hyperparathyroidism needs surgery. These are the indications. If the calcium is consistently above 2.85, we would refer them for surgery. If they've got complications in the form of renal stones, if they've got osteoporosis, and if the age is less than 50. Less than 50 because they've got more years to live and develop complications, basically. However, if the corrected calcium remains below 2.85 and the patient's asymptomatic with no complications, we simply monitor them every 6 months or so. Okay, so another case also related to the bone is a 57-year-old lady who falls and sustains a fracture of her wrist. So she has her wrist sorted by the orthopods, and then you see her in your clinic. Going through her history, she's got celiac disease, diabetes, hypertension. She's on these medications. She smokes, drinks about 3 glasses of wine per week, and her mother had a fracture at the age of 86. So just have a look and see what of these are considered risk factors for a fracture. Smoking, yeah, indeed. Yeah. I'm just going to highlight now which are the risk factors. So indeed, yeah, Lansopra is also, the age obviously is postmenopausal, which is a risk factor. Celiac disease, diabetes, proton pump inhibitors, and smoking. The reason I haven't highlighted the family history, it tends to be more relevant if it's less than the age of 80. When it's 86, you'd expect if somebody falls, they're going to break their hip. So it tends to be more relevant as a risk factor if it's less than the age of 80. So other questions you would ask this patient is dietary habits, whether they, eat dairy products. You want to see if they're eating enough, having enough calcium in the diet. Age of menopause, if she's had an early menopause, that's a risk factor, if it's below the age of 45. And physical activity. So physical activity is important for the bones, especially weight-bearing activity or brisk walking. Things like swimming tend to be less useful for the bones. They obviously have other benefits, but for the bones you need weight-bearing exercise. Other tests you would do, this lady sustained a fracture, so you want to see whether she needs to go on bone protection. You would ask for a bone density scan and DEXA scan, check vitamin D levels, and if you find that her bone density is below expected for age, then you need to look for secondary causes of osteoporosis by doing these tests, full body count using these LFTs, calcium profile, vitamin D, ESR and immunoglobulins for myeloma, celiac screen, thyroid function, and if it's a man, fasting testosterone. Because hypogonadism is a cause for low bone density. This is just to show you the DEXA scanner, and the two images we tend to do is the lumbar spine, the hip and the neck of femur. In patients with hyperparathyroidism, we also check the radius because they tend to have osteoporosis affecting their radius. Another image we tend to do is an image of the whole spine, all the vertebrae. It's not as good as an X-ray, but it does give some indication if there's any vertebral fractures. This is the FRAX. I don't know if you're familiar with the FRAX. This is something you can access online, and it gives you some indication as whether the patient is considered high risk and whether they need any treatment. So you put the patient's details, their age, weight, height, if they've had a fracture before, any family history of fracture, if they're on steroids. It doesn't cover everything. For example, it doesn't put if the patient's having recurrent falls, which is a high risk. And then you put the results of the bone density, click calculate, and tells you the risk. So for example, in this patient, the risk of having a major osteoporotic fracture in 10 years is 24%. And the risk of having a hip fracture in 10 years is 8.2%. And then if you click on that, it gives you some kind of guidance as to whether the patient falls into the high risk area or low risk area. So if it's in the red area, this patient needs bone protection. If it's in the green area, not necessarily. However, this is a guide, and even in some patients, if they fall in the green area, we would still start treatment. For example, this is the graph of a patient who had a T-score of minus 2.6, so the patient was osteoporotic, and she'd had a hip fracture. So going by NICE criteria, the patient needs to go on treatment for secondary prevention, but if you go by this, she falls in the green area. So it's just a guide. When it comes to treatment, so there's lifestyle measures and medication. All patients need to be on calcium and vitamin D. It's always worth checking the vitamin D first, because if it's significantly low, they would need a loading dose of vitamin D, like 50,000 units once a week for 6 weeks, and then they go into a maintenance dose of 1,000 units a day. Exercise is important. Obviously, if they're smoking, stopping smoking. Falls management, referring them to the falls clinic, and avoid heavy alcohol intake. When it comes to medication, bisphosphonates are the main medications we use. They've been around for a long time. They're safe. They're effective. Most patients go for the oral form, like once a week alendronate. If they can't tolerate it, then we can give them the intravenous zolendronate. It's once a year for 3 years. The tablet form is a course of 5 years. If it's the intravenous form, it's a course for 3 years, once a year. Then you can give them a break for 2 to 3 years as a drug holiday, repeat the scan, and assess whether the patient needs to go back on treatment. As mentioned, they also should be on calcium and vitamin D. There are other options which tend to be used if the patient cannot tolerate the bisphosphonates or they continue to have fractures on the bisphosphonate. There's denosumab, which is subcutaneously every 6 months. And then there's things like estrogen if somebody has an early menopause, raloxifene, and PTH. Okay, so moving on to a different case. A 47-year-old man attends for a regular checkup. You do the HbA1c and it's 44. So it's not normal, it's not quite diabetes, it's in between, what we call pre-diabetes. So what this patient needs is an oral glucose tolerance test. And the patient had a fasting glucose of 5.8 and a 2-hour glucose of 8.9. So that's abnormal. Normally it should be less than 7.8 after 2 hours of the glucose load. So this patient has impaired glucose tolerance, i.e. pre-diabetes.
Excuse me, would you always do an OGTT if using somebody's
I think ideally yes, because quite often you find that by doing the OGTT they do have diabetes. Yeah. Fair enough. I mean, if that's national guidance, yes. But in practice, we find that when we do it, quite often we find they do have diabetes. So I don't want to confuse you, but in real practice, sometimes we find that they do have diabetes. Yeah. Okay, so pre-diabetes involves two things. It's the impaired fasting glucose and impaired glucose tolerance. It's a significant risk factor for development of diabetes. And that's why we check for diabetes. And the important thing about pre-diabetes, that patients start developing the complications from that stage. So microvascular complications and macrovascular complications can start from that stage. So it's important to be managed. As mentioned, it's an intermediate stage between normal and diabetes. If it's impaired fasting glucose, so the fasting glucose is going to be between 6 and 7, because less than 6 is normal, more than 7 is diabetes. And if we do the glucose tolerance test, the 2-hour blood sugar is more than 7.8 but less than 11. If we go by the HbA1c, it's between 6 and 6.4, or between 42 and 48. And the risk of developing diabetes is about 5 to 10% per year. So every patient with pre-diabetes has a 10% risk of developing diabetes per year. Yes, so the next few slides. Yeah. These are just to go through the criteria for screening for diabetes, which in a way also covers pre-diabetes. If you have a white patient or a patient of ethnic background, if they're white and more than 40, or ethnic background more than 25, with first degree family history of diabetes, you should screen them for diabetes. If they're overweight, you should screen them for diabetes. And if their waist measurement is above a certain kind of cutoff. Regardless of their age and background, if they have ischemic heart disease or a stroke in the past, they should be screened for diabetes. If there's a history of gestational diabetes, polycystic ovaries, severe mental health problems, there's just evidence that patients with severe mental health problems have more incidence of diabetes. And some of their medications, like olanzapine, increase the risk of diabetes. And if somebody has high triglyceride not related to alcohol, you should screen them for diabetes. Management of pre-diabetes, really the mainstay of management is lifestyle adjustments. And 2 large studies have shown that that's the most effective way of treating pre-diabetes. 58% reduction in the progression to diabetes with intensive lifestyle changes, which mainly involves a 7% weight loss and physical exercise of 150 minutes per week. And the risk reduction was best in patients who maintain these lifestyle changes. In certain cases, you may consider using metformin. This is especially in people who are considered to be a high risk of developing, or let's say a higher risk of developing diabetes, especially if they're below the age of 60, on the basis they've got more years to develop diabetes. If they're obese with a BMI of more than 35, or if the patient has had gestational diabetes in the past. So in these patients, you may well consider starting metformin at the pre-diabetes stage, in addition to lifestyle changes. In any patient with prediabetes, you should look for other risk factors for cardiovascular disease, checking their cholesterol, their lipid profile, and ensuring their blood pressure is under control. And they should be monitored annually for the development of diabetes. Thank you. So, slightly faster than the 90 minutes, but I'm more than happy to take any questions.
Last question.
Yes.
How do you distinguish between care? I know the studies have shown the lifestyle, but the conditions that you produce in the last studies are not translated to primary care.
Sure.
Because you just don't have the backup to do that. So should we be having all these patients with all the also evidence to suggest this?
Sure. There was actually a slide which I haven't put, which compared metformin to lifestyle. And there was actually a significant difference that lifestyle was much more effective than metformin.
But they will under trial conditions.
Fair enough, fair enough. So obviously these are all guides, and if you feel the patient is unlikely to benefit simply from just lifestyle, you can always add in metformin, especially when it says like a BMI of 35. If somebody's got a BMI of 30, and you feel this patient is, if anything, the HbA1c is progressing more towards diabetes, yeah, indeed, you can start metformin. But as a general guidance, these are the criteria. Mm. Yes. I mean, always it's worth trying the metformin slow release. And a good proportion of patients who can't tolerate metformin would tolerate the metformin slow release. Sure, yeah. There is no kind of national or international guidance on starting a different medication. There's no evidence that any other medication would make a difference. So really it is lifestyle adjustments, and if the patient develops diabetes, then you start, other medications. But there isn't evidence that anything else would make a difference. Yeah. Questions on any other topics? No? Yes, if the oral type of calcium, that's fine. Obviously, you'd like to check the vitamin D. If the vitamin D is normal, then that's fine. I mean, most of the population have low vitamin D, but if it's normal and they're eating a fair amount of, calcium-rich diet, then you're fine. Indeed, indeed, yeah. Okay, thank you.
Thank you, Dr. Merza.